Good morning. My name is Seonggon Kim Hin Kutgangyong Wonju National University. It is my great honor to have the opportunity to present my work at this meeting. Although we are meeting virtually today, I sincerely hope that we will have the chance to meet face-to-face in the near future. In this presentation, I will discuss bridging bench and bedside in oral cancer management for older adults, integrating clinical experience with basic research to address the unique challenges of an aging population. According to SEER data from 2018 to 2022, elderly patients represent a substantial proportion of newly diagnosed oral cancer cases. However, the burden is not uniform. Disease stage at diagnosis plays a critical role in determining survival outcomes, treatment feasibility, and functional prognosis. Older patients frequently present with multiple comorbidities, including chronic obstructive pulmonary disease, liver dysfunction, and cardiovascular disease. Frailty and reduced physiologic reserve significantly limit tolerance to chemotherapy, radiotherapy, and prolonged surgical procedures. As a result, treatment decisions must balance oncologic control with preservation of quality of life. In early-stage oral cancer, surgical treatment alone can achieve excellent local control and long-term survival. In contrast, advanced-stage disease is associated with poor prognosis, and aggressive multimodal therapy is often not feasible in elderly patients. This highlights the importance of stage-specific strategies. These realities compel us to reconsider conventional treatment paradigms for oral squamous cell carcinoma in older adults, moving beyond a one-size-fits-all approach. A new approach must address two key elements. First, cancers must be detected at an earlier stage, when treatment is less invasive and more effective. Second, management strategies should emphasize minimally invasive surgery. At the same time, advances in basic research, including work on 4-hexylresorcinol, offer promising adjunctive therapeutic potential. Epidemiologic data reveal population-level trends, but real-world outcomes are shaped by individual factors. Comorbidities, treatment tolerance, social support, and stage at diagnosis all influence prognosis. To understand treatment success in elderly patients, we must shift our focus from statistics to individual clinical realities. In elderly patients, aggressive therapy is often limited by comorbid conditions. Prolonged anesthesia is poorly tolerated, and the risks of pulmonary, hepatic, and cardiovascular complications increase significantly with age. These constraints frequently necessitate treatment modification. For stage 1 and 2 disease, surgery alone can yield favorable outcomes, even in older adults. However, for stage 3 and IV disease, elderly patients are often undertreated due to medical limitations. In these cases, functional outcomes such as swallowing, nutrition, and speech frequently become primary goals. Postoperative recovery in older adults is often prolonged. Wound healing is slower, nutritional management is challenging, and susceptibility to infection is increased. In some cases, maintaining dignity and quality of life outweighs the goal of extending survival. I would now like to present a representative clinical case involving a 90-year-old patient diagnosed with oral cancer. Despite advanced age, a comprehensive clinical and radiographic evaluation was performed to determine the feasibility of curative treatment. The image on the left shows a clinical photograph of the oral lesion. An ulcerative lesion is visible in the edentulous area of the left maxilla, where the patient was wearing a removable denture. The panoramic radiograph demonstrates localized bony erosion beneath the lesion, suggesting underlying osseous involvement. Pre-treatment assessment included computed tomography and positron emission tomography imaging. Importantly, treatment decisions were guided by the patient's physiologic status rather than chronological age. On the left, the computed tomography image shows no evidence of maxillary sinus involvement. On the right, the positron emission tomography computed tomography scan demonstrates a highly metabolic hotspot in the left maxillary region corresponding to the primary lesion. This individualized imaging-based assessment formed the basis of our management plan. A minimally invasive but oncologically curative surgical approach was selected. The primary objective was to achieve complete tumor control while minimizing surgical stress and preserving oral function. In the left intraoperative image, a predefined safety margin was established, followed by complete excision of the tumor. All surgical margins were carefully assessed and confirmed to be tumor-free. The right intraoperative image demonstrates reconstruction of the surgical defect using a pedicled buccal fat pad graft, providing effective coverage with minimal additional morbidity. Careful preoperative planning and intraoperative decision-making were essential to reduce perioperative risk in this very elderly patient. The patient recovered without major postoperative complications. Swallowing and speech function were preserved, and overall postoperative quality of life was maintained. The clinical image on the left shows the postoperative appearance at 2 months. The oral wound is completely healed, with no evidence of dehiscence or infection. The postoperative computed tomography image on the right, obtained 3 months after surgery, demonstrates an intact maxillary sinus with no radiologic evidence of local recurrence. This case clearly illustrates that advanced chronological age alone should not preclude curative intent treatment. This case illustrates that, with careful patient selection, curative treatment is feasible even in very elderly individuals. Early diagnosis and minimally invasive surgical strategies are critical to achieving favorable outcomes. Unfortunately, many oral cancers in elderly patients are diagnosed at an advanced stage. When detected at stage 1 or 2, surgical treatment offers excellent survival with limited morbidity. This underscores the importance of early detection. General dentists serve as frontline gatekeepers in oral cancer detection. Routine oral examinations in elderly patients, particularly those with known risk factors, can dramatically improve early diagnosis rates. When visual inspection alone is insufficient, adjunctive diagnostic tools can be helpful. Toluidine blue staining, autofluorescence devices, and brush cytology support clinical vigilance. However, biopsy remains the definitive diagnostic standard. Research is rapidly advancing toward non-invasive screening methods. Salivary DNA and RNA markers, circulating tumor DNA, microRNAs, and metabolomic profiling show promise. These approaches may be particularly beneficial for elderly populations. 4-hexylresorcinol, or 4-HR, is a small organic compound traditionally used as an antiseptic and food preservative. More recently, it has attracted attention for its potential anti-cancer properties. In this experiment, we evaluated the direct anti-cancer effects of 4-hexylresorcinol in oral cancer cell models. Following treatment with 4-HR, we observed the formation of clear apoptotic bodies, indicating morphologic changes consistent with programmed cell death. To quantitatively confirm apoptosis, annexin V staining was performed. Compared with untreated controls, 4-HR-treated cells showed a marked increase in annexin V-positive populations. These findings demonstrate that 4-hexylresorcinol directly induces apoptosis in oral cancer cells, providing strong experimental evidence for its anti-cancer activity. Calcium signaling plays a central role in regulating cancer cell survival, proliferation, and apoptosis. In oral cancer cells, tightly controlled intracellular calcium oscillations are essential for maintaining cellular homeostasis. Disruption of these oscillations can trigger apoptotic signaling pathways. In our experiments, treatment with 4-hexylresorcinol altered intracellular calcium dynamics, leading to abnormal calcium oscillation patterns. These changes in calcium signaling shifted the balance from cell survival toward apoptosis, suggesting that modulation of calcium homeostasis is one of the key mechanisms underlying the anti-cancer effects of 4-HR. This slide summarizes the proposed molecular mechanism underlying the anti-cancer effects of 4-hexylresorcinol. In oral cancer cells, transglutaminase2 plays an important role in activating the nitrogen monofluoride kappa B signaling pathway, which promotes cell survival, proliferation, and resistance to apoptosis. Under normal conditions, NF-kappa B is retained in the cytoplasm by its inhibitor I-kappa B. When I-kappa B is phosphorylated and degraded, NF-kappa B translocates to the nucleus and activates survival-related gene expression. Our data show that 4-hexylresorcinol inhibits transglutaminase2 activity, thereby stabilizing the I-kappa B and F-kappa B complex. As a result, NF-kappa B activation is suppressed, leading to reduced transcription of pro-survival genes and enhanced susceptibility of oral cancer cells to apoptosis. In addition to inducing apoptosis, 4-hexylresorcinol also promotes tumor cell differentiation. In cancer biology, loss of differentiation is closely associated with aggressive behavior, increased invasiveness, and poor clinical outcomes. Following treatment with 4HR, we observed phenotypic changes consistent with enhanced cellular differentiation, suggesting a shift away from a highly malignant state. This differentiation-promoting effect may reduce tumor aggressiveness and malignant potential, thereby complementing the pro-apoptotic effects of 4HR in oral cancer cells. In this study, we evaluated multiple treatment regimens using patient-derived oral malignant melanoma cells. Several of the tested agents were drugs that are currently approved for the treatment of melanoma. However, despite their clinical approval, none of these standard melanoma therapies demonstrated meaningful anti-tumor activity against the patient-derived oral malignant melanoma cells in our experimental system. In contrast, the combination of cisplatin and 4-hexylresorcinol showed the strongest anti-tumor effect among all regimens tested. Treatment with 4HR alone also exhibited anti-tumor activity, although its effect was weaker than that observed with the combination therapy. These findings were further validated in xenograft models, where the combination of cisplatin and 4HR significantly suppressed tumor growth compared with the cisplatin-only group. Based on these results, we had planned to explore this combination as a potential therapeutic option for the patient. Unfortunately, the patient passed away during the course of our research, and clinical application was not possible. Nevertheless, these data suggest that combining conventional chemotherapy with molecular modulators such as 4HR may represent a promising strategy for treatment-resistant oral malignant melanoma. We next examined the effects of 4-hexylresorcinol on tumor metastasis using in vivo experimental models. In these models, administration of 4HR resulted in a significant reduction in metastatic spread compared with control groups. This anti-metastatic effect was associated with suppression of cellular invasion and migration pathways, which are critical steps in the metastatic cascade. By limiting the ability of cancer cells to invade surrounding tissues and establish secondary lesions, 4HR may contribute not only to primary tumor control, but also to reduced metastatic potential. The tumor suppressor protein p53 plays a central role in maintaining genomic stability by regulating cell cycle arrest, DNA repair, and apoptosis in response to cellular stress. In oral squamous cell carcinoma, p53 is mutated in approximately 50 to 70% of cases. These mutations most commonly occur in the DNA binding domain of the p53 protein, which is essential for its transcriptional activity. As a result, mutant p53 loses its ability to activate tumor suppressor pathways, allowing damaged cells to survive and proliferate, thereby contributing to oral cancer development and progression. Under normal conditions, wild-type p53 functions as a critical cellular checkpoint. When DNA damage occurs, p53 is activated and induces cell cycle arrest, allowing time for DNA repair, or alternatively triggers apoptosis if the damage is irreparable. In contrast, when p53 is mutated, these protective responses are lost. Mutant p53 fails to properly sense DNA damage and cannot activate downstream tumor suppressor pathways. As a result, genetically unstable cells continue to proliferate despite accumulating DNA damage, which promotes tumor progression and therapeutic resistance. Our data indicate that 4-hexylresorcinol directly interacts with the DNA binding domain of p53, which is the region most frequently mutated in oral cancer. Panel A shows amino acid sequence-based peptide conformation predictions. The mutant p53 peptide, p53 ALA258, exhibits a random coil structure, whereas the wild-type peptide, p53 GLU258, forms a stable beta sheet conformation. Panel B presents the Fourier transform infrared spectra of each peptide, demonstrating characteristic absorption bands in the amide I, amide II, and amide III regions, confirming their distinct secondary structures. In panel C, the amide I peak corresponding to carbonyl stretching in P53-ELA258 treated with 4HR is less enhanced than that of P53-ELA258 alone, indicating a structural modification induced by 4HR. Panel D further shows that wild-type P53-GLU258 displays multiple beta sheet peaks, whereas mutant P53-ELA258 shows a simplified conformation. Importantly, when mutant P53-ELA258 is coupled with 4HR, its structure shifts toward a beta sheet-rich pattern, resembling that of wild-type P53. Together, these findings suggest that 4HR stabilizes the DNA binding domain of mutant P53, potentially restoring partial structural and functional integrity. As a functional consequence of 4-hexylresorcinol treatment, cancer cells demonstrated recovery of apoptotic and cell cycle regulatory capacity, supporting the concept that 4HR acts as a molecular stabilizer of dysfunctional P53. Panel A shows the in vivo xenograft model in which grafted tumor masses were established in the sublingual area. Tumor size was measured serially using an electronic caliper, and at the time of euthanasia, tumor specimens were collected for histological analysis. In panel B, because the initial tumor sizes differed among animals, tumor growth was evaluated using the ratio of mass size at each time point relative to the initial size. Although the relative tumor mass tended to be higher in the control group than in the 4HR treated group, the difference did not reach statistical significance. Panel C presents histological and immunohistochemical findings. Hematoxylin and eosin staining revealed that mitotic figures, indicated by arrowheads, were more frequently observed in the control group. Immunohistochemical analysis showed similar expression levels of BCL2 between groups, whereas the expression levels of the pro-apoptotic proteins BAX and BAD were higher in the 4HR treated group. Together, these findings indicate that 4HR suppresses tumor cell proliferation and promotes apoptotic signaling in vivo, even in the absence of a significant reduction in tumor volume. This slide provides functional evidence that 4-hexylresorcinol induces apoptosis in TP53-mutated oral cancer cells. In panel A, cancer cell proliferation is significantly inhibited following 4HR administration, indicating a direct anti-proliferative effect. Panel B shows YD15 cells treated with 100 micromolar 4HR. The cytoplasm exhibits green fluorescence, reflecting the release of cytochrome C from mitochondria, which is a hallmark of mitochondrial-mediated apoptosis. In panel C, we examined the expression of apoptosis-associated proteins. Following 4HR treatment, the levels of the pro-apoptotic proteins BAD and BAX increased in both a time-dependent and dose-dependent manner. Together, these findings demonstrate that 4HR suppresses cancer cell growth and activates mitochondrial apoptotic pathways in TP53-mutated oral cancer cells. This slide further elucidates the mechanisms by which 4-hexylresorcinol induces apoptosis in TP53-mutated oral cancer cells. In panel A, YD15 cells were transfected with TP53 siRNA, which successfully suppressed P53 expression. Under these conditions, the expression level of the anti-apoptotic protein BCL2 was not dependent on the presence of P53. Importantly, when 4HR was administered to TP53-mutated YD15 cells, the expression of the pro-apoptotic protein BAX was increased. Notably, BAX expression was also increased following TP53 siRNA transfection, indicating that BAX induction can occur independently of P53. In addition, 4HR treatment increased the expression of the pro-apoptotic protein BAD in a P53-independent manner. Panel B shows that P53 transcriptional activity in YD15 cells was significantly increased following 4HR administration. Consistent with this, the expression levels of the apoptosis-associated proteins BID and BAX were elevated in both a time-dependent and dose-dependent manner after 4HR treatment. As illustrated in Panel C, mutant p53 normally exhibits reduced transcriptional activity due to alterations in its DNA binding domain. However, when 4HR binds to mutant p53, conformational changes may enhance its DNA binding ability, leading to partial recovery of p53 transcriptional activity. Together, these results demonstrate that 4HR promotes apoptosis through both restoration of mutant p53 function and activation of p53-independent apoptotic pathways. Early detection by general dentists remains the cornerstone of improved outcomes. Basic research advances, including 4HR and biomarker development, add an important translational layer. In elderly patients, shorter and less invasive surgical procedures are generally preferred in order to minimize perioperative risk and functional impairment. In this case, 4-hexylresorcinol was applied topically in a palliative postoperative setting. When we examined the patient's tissue samples after topical 4HR application, we observed clear molecular changes. The expression of keratin 10, which is a well-established marker of epithelial differentiation, was increased following 4HR treatment. This finding indicates a shift toward a more differentiated and less aggressive cellular phenotype. In contrast, the expression of Ki67, a marker of cellular proliferation, was decreased after topical 4HR application. Together, these results suggest that topical 4HR promotes cellular differentiation while suppressing proliferative activity even after surgical intervention. Clinically, this supports the potential role of 4HR as a supportive molecular therapy in elderly patients undergoing minimally invasive or palliative oral cancer surgery. Looking ahead, future strategies in oral cancer management must be specifically tailored to the elderly population. This includes the development of age-adapted treatment algorithms that account for comorbidities, functional status, and quality of life considerations, rather than relying solely on conventional oncologic staging. At the same time, it will be essential to strengthen translational pipelines that connect basic research findings, such as molecular modulators like 4-hexylresorcinol, with real-world clinical application. Finally, effective multidisciplinary collaboration among dentists, surgeons, oncologists, and basic scientists will be critical to improving outcomes for older patients. In conclusion, oral cancer in elderly patients presents unique clinical challenges related to comorbidities, treatment tolerance, and preservation of quality of life. Early detection by general dentists is essential, as diagnosis at an early stage allows for less invasive treatment and significantly improved outcomes. For older patients, minimally invasive surgical approaches offer the safest and most effective strategy for achieving tumor control while preserving oral function. In parallel, basic research, particularly studies focusing on 4-hexylresorcinol and p53 signaling, demonstrates strong translational potential by providing molecular strategies that complement surgical management. Together, the integration of early detection, tailored surgical approaches, and translational research bridges bench and bedside, offering a more effective and patient-centered approach to oral cancer care in the aging population. These are the key references that support the data and concepts presented in this talk. In addition, I have published a book titled Biomedical Application of 4-hexylresorcinol, which provides a comprehensive overview of the biological mechanisms and translational potential of 4-hexylresorcinol. The book is published by Springer and is available through the Springer website for those who may be interested in further details. Thank you very much for your attention. I sincerely appreciate your interest in this work and in the integration of clinical practice with basic research in oral cancer management. I would be happy to take any questions or comments. If you prefer, questions can also be sent to my email address, which is provided on this slide. Thank you once again.